We're Sentia Health. We're in the business of streamlining and automating processes and have even automated the production of new software. Usually we talk about the state of healthcare and health insurance in the US, but today is a little different. We are going to talk about electronic medical records, how they are designed and built, why that design is overly complicated and, well, just wrong. Then we will talk about a better path forward, that is, how to do it right. We will demonstrate not only why the medical software companies are approaching their products the wrong way, but a better way to think about medical records. All of the currently produced electronic medical record systems, EMRs, are either written for one or two medical specialties, or are individually written for all 135 plus specialties. This makes every specialty an island with its own documentation style and nomenclature, or with the large EMR providers, a conglomerate of all 135 that all require individual training courses called modules that span up to 6 weeks each. That means that if a doctor wanted to learn all the modules in Epic, it would take him or her 4 to 8 years longer to learn than the entirety of medical school and residency. At least they would get to spend those 15 plus years in Vegas at a convention center being paid for by their employer. In addition to the training problem, we have either hundreds of individual applications built in nobody knows what, like Cerner, or built in an ancient 60-plus-year-old language like Mumps, as Epic is. These number of applications is wholly unmaintainable. There is no code reuse, takes decades to write, costs hundreds of millions of dollars per hospital or practice, and frequently just fails. By fails, I mean completely quits working, forcing the practice to rely on paper. What other industry has 135 plus specialties? While there probably aren't many, there isn't one that has 135 different pieces of software to handle them. It's true that you don't want a cardiothoracic surgeon managing your anesthesia and your anesthesiologist doing a triple bypass. The way these two things are documented, however, is exactly the same. Let us consider the common experience of taking your car into the shop. You pull up and the service writer asks you to describe your problem. He or she writes that down and passes it to the technician. Let's say that your car is overheating. The tech gets the car, sees that the symptom is car is overheating, and does an examination and decides you need a water pump. He writes remove and replace water pump in your case notes. Then he removes and replaces your water pump, tops off or replaces your coolant, and off you go. From a documentation perspective, there is no difference between performing that procedure on a Ferrari or a Maserati. You could make an argument that a Volkswagen Beetle is a little different, but you simply wouldn't document a water pump on one of those. The point is that you don't see your mechanic shop having a water pump record system, or a differential record system, or a coil spring record system. Why is it that medicine does things one way and everyone else in the world does it another? We think the difference is mindset. Doctors do one thing, do it very well, and move on. Engineers look at the class of a problem, reduce it to its component elements, and then solve the general problem. It is a little like the difference between mathematics and algebra. You can state that 2 plus 2 equals 4. This is an irrefutable statement. This is how medicine thinks. It works, but it only works in that one case. An engineer might think, what if I had a 3 in there, or an apple, or a giraffe? Then he might state A plus B equals C, solving all the variations of this general problem. It seems that we should then be trying to solve this general problem by looking at shared functionality and detailing the differences and how to deal with them. Here is where the metaphor breaks down. The dealership you take your car to doesn't have a universal set of diagnoses or procedures. They use whatever they are given or buy. There isn't a hue and cry to transfer data easily between mechanics or dealerships. There is a need to transfer data between hospitals and practices. Luckily, people are far more similar to each other than a Ferrari 360 Modena is to a Volkswagen Beetle, and some of those similar people at the National Institutes of Health have come up with a universal medical language system called, oddly enough, the Universal Medical Language System that assigns discrete, structured values and definitions to anything can be measured or done to a human body. Only with this universal diagnostic definition set can we achieve interoperability and easy transfer of medical records between systems. What we need then is to break down what we really need to know for each medical specialty and what is similar between them. Then we come up with a solution only for the things that are different between specialties. At its base, a medical record needs to know a list of complaints, few measurements, some observations, and a plan on how to make the patient healthy. Just like the overheating car in our earlier example, this should be fairly simple. As stated previously, the UMLS is a database including SNOMED CT, the systematic nomenclature of medical and clinical terms, a suite of designated standards for use in U.S. federal government systems for the electronic exchange of clinical health information. RxNorm normalized names for clinical drugs and links its names to many of the drug vocabularies commonly used in pharmacy management and drug interaction software. And VSAC, Value Set Authority Center, a repository and authoring tool for standard lists of codes and terms from biomedical vocabularies. These document, as mentioned, everything that can be done to a human, including drugs, and also include over 180 different medical nomenclatures like Epic and Cerner, allowing the user to easily translate between UMLS and any other source of data or between any two disparate sources. The best part is that the documentation is all written in such a way that it is all self-referencing, meaning that if you figure out how to use one, you've figured out them all. At its core, a measurement is a key value pair, KVP. You have the name of the measurement, the magnitude, and some units. For example, key equals length, value equals 62, units equals inches. While it is slightly more complicated than that, this description gives a good overview of the design. The key could be picked from a list, as could the units. These two lists or lookups should be not only data-driven but preloaded. By that I mean that the measurement name and the units are both pulled out of the database so we don't get typing mistakes, but can be edited easily with no additional coding required for new and changing measurements. Maybe we need a new measurement for rutabagas per cubic snorkel. You can just add it to the database and start using it. Also necessary for a universal EMR is the ability to automatically ingest machine-generated data from a vitals monitor. There are several standard formats for this data transfer, HL7 being the most common. There are things that have to be documented about a patient encounter that aren't needed for each kind of encounter. We propose to solve this with a survey tool. This is a fully configurable dynamic tool that allows the user to create checklists, unstructured notes, unstructured measurements, like a blood pressure and heart rate when a patient moves from surgery to recovery, and things of that nature. The hospital or practice can configure their own questions and answer types, or we can suggest these to them and then modify the suggestions as necessary. These things can be made mandatory, that is, must be answered, and hierarchical, such as a "do you like ice cream?" Having a follow-up question with a multi-select full of ice cream flavors labeled "what kinds?" This allows the practice to modify their own version of the application to do whatever it is that they think is necessary and requires no additional code, deployment, or installation. Even better, we already have this tool and the associated printable and savable reporting structure for it completed and ready for use. We have proven that current EMRs are badly designed, require months or years of worthless training, sometimes just fail, and are monumentally, amazingly, idiotically expensive. We have further shown that all this work on current EMR software just doesn't need to be done. It is born out of a one problem, one solution mindset prevalent in medicine that is just wrong. We have demonstrated a three-pronged approach to building this new system that includes UMLS, a flexible measurement framework that accounts for automatic measurements, and a survey tool suitable for handling things that are specialty specific. This EMR does everything it needs to do and is lightweight, fast, inexpensive, and requires no training. We have the system in prototype version right now and are working on the production version. Contact us for demonstration. Read the text version of this video on our newsletter site, senshahealth.substack.com, or click the link to it in the pinned comment. All of the referenced material will also be linked in the pinned comment. We appreciate your attention and help with promotion and invite you to tell us your thoughts in the comments. We will make every effort to read and answer every comment. Part of the reason we do this is to educate you and help you to educate others. Help us help you and every insured person in the world by clicking like and subscribe, telling the algorithm to show this to more people. Until next time.